So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Yeah? Good evening, everyone. Welcome back live and in person to the Lung Cancer Living Room. We finally made it back to in-person meetings, and I, for one, could not be more thrilled. And I think the sentiment has been shared based on all of the conversations that I've had gotten to have with you all since you walked in the room. So thank you all so much for coming. Thank you all online who might be watching from your very own living rooms tonight. We're so happy to have you here. And I want to let everybody know that typically, pre-pandemic, we did it around the room. But as you can see, there are a lot of people in this room tonight. So doing the around the room in this format will take up the whole 2 hours. So for those of you who don't know, the Tuesday right before this meeting, we have a gathering called Gathering Hope. Michelle Zay, who all of you remember over here in the corner, and Miranda Goff, who's our colleague back in the DC area, oversee what is effectively and around the room. And it's an opportunity for you guys to go and meet one another. I know Larry's a frequent flyer in the Gathering Hope meetings. And it's really a great space for you all to just have those conversations with one another. So if anybody wants more information, if you haven't been able to join, please, please, please ask us and or ask Michelle, and she'll be able to guide you to those meetings. Another thing you might notice is that we don't have food tonight. I promise next month we will have food. Because this is an open forum for anyone to come, we don't ask for RSVPs. If we've got to put folks up on the mezzanine, then we've got to put folks up on the mezzanine. But we wanted to kind of gauge what the interest would be, and based on tonight's attendance, the interest is high. So I'm really, really excited. And now we know how much food to order for next month. So thank you all for being here. For those of you who are watching live online who may not be familiar with this program, maybe it's your first time, this Lung Cancer Living Room is designed and created for you, the patient, the person living with lung cancer, for the caregiver who is caring for the person living with lung cancer. We really designed it with you in mind, with the hopes of bringing to you live and in real time topics running across the board about lung cancer. Anything you guys could think of that you might want to hear about. We invite expert speakers from around the country, and really in some instances from around the world, to come in and have those conversations with you. This really gives you guys an opportunity to have access in real time to thought leaders that you might not otherwise have access to. I know some of you in the room tonight might have Dr. Neal as your healthcare provider, which is fantastic. But a lot of you don't. So I encourage questions throughout. Like I said, this programming is meant for you. So before we get started and jump into, I'm going to ask Dr. Neal to introduce himself. I could read through his bio, but that feels very impersonal. But before we do that, Mr. Ron Fong, who is in the audience tonight, Ron is a long-time attendee of the Lung Cancer Living Room. He lost his wife, Joan, to lung cancer, but continues to fight the fight for everyone else. And tonight, he's going to talk a little bit about an awareness campaign that I think most, but not all, might be aware of, and how you might be able to participate. Ron? Yeah, you can do whatever you want. Just grab a mic.
Don't give him that much.
I am excited to be back here, as well as everyone else, to be in person. So we can actually nudge people like Wayne and say hi. But I wasn't able to make Washington D.C. But at Washington D.C., where we at the Voices Summit, we lobbied Congress to let them know that lung cancer matters, that everybody matters, and to make them more aware. A project was started about a year ago by a doctor and his wife who has lung cancer, is the White Ribbon Project. So these are white ribbons. They're plywood. They're made out of hand-carved or hand-sawed by other lung cancer patients or advocates, as well as doctors and researchers. And on the back, we sign them and let them know that you're not alone. I've got 6 of them here for anyone who wants to take one, to help know that you're not alone, that we're in this fight with you. And I have some blank ones there that people can take. They're not painted yet, and they're sawed out. and we can then use those to make templates to make more white ribbons. And so for that, anyone who wants one, who didn't get one, who is listening, just email us and we'll take care of it and get you one. Thank you.
Thanks, Ron. And like Ron said, we've got some that are ready to go and some that are ready to be signed. So please feel free to sign your name to the back of these because they do land in the hands of lung cancer patients really around the country. Heidi, who's a lung cancer
And physicians
and the world.
group
Yeah.
offices.
Heidi, who's a lung cancer patient herself, started this sort of movement to generate awareness, and it's really taken off. And GoTo's really proud to say that we are partnered with her wherever we can in spreading the word about spreading the word. So thank you, Ron, for bringing that up. Now I kind of want to jump in. What I will say is if you guys have questions tonight, that's the time to introduce yourself. Say who you are, whether you're a caregiver, an advocate, or a person living with lung cancer, so that we know who's talking to us, or Dr. Neal knows who's talking to us. But please, we really do encourage questions throughout. There's no need to hold. And I know a lot of you are old veterans and you remember what the drill is here. But tonight we're talking about the next wave of precision medicine, which I think is really exciting. You guys have heard us talk about precision medicine, what that is and what that means for quite a while now, thank goodness. But now we're talking about the next wave. But before we jump into the next wave, for the folks who might be newer to this space, newly diagnosed, and not really understand what that means, we're going to be talking about precision medicine as it is today. And I just looked over at my mom and remembered that I got so excited just about looking out into the crowd and talking that I forgot to talk about her. I'm going to let her tell you the bulk of the story, but I think most of you have seen by now, either through emails or in newsletters or on social media, that she has decided to step down and retire, at least from her chairwoman of the board position and any sort of business, sort of, day-to-day, I guess, position at the foundation. She still is staying on the board of directors, and of course, she's still staying involved in projects that she's currently working on and will continue to stay involved in anything that has to do with patient touch or patient voice along with me. So, Mom, I'm going to turn it over to you just to say a few words before we... Don't take too long, though.
So here's what happens apparently when you retire. You get a plastic glass.
Oh.
Nice going glass. Got a plastic glass. What is that?
Okay.
So I was telling our new girl today that
Karen.
She's only been here a very short time. I said, "This is your second home. Just know that's what happens here. This is your second home. You have a daughter. You have to take her to cheer. We're good with that. We're good with anything. But anyway, here I am, and I've been thinking about retiring for a while because I wanted my daughter to take over. And she is certainly more than qualified. And she's doing an absolutely great job. So every once in a while, she throws me a little crumb to do.
Not true.
And occasionally, she doesn't know what she's talking about. So she asks me.
Talk in the mic so people can hear you.
I don't think this is working.
It's not working in here, but it's working online. You just have to talk loud for it in here. Yeah.
And then the thing that really made me decide to retire was I got an aortic aneurysm. Does anybody know? Well, you know what that is. It's not good. It's not good. So I'm going tomorrow up to UCSF to get results from a gazillion tests, but I already had a 9-hour surgery. And so I'm here. I'm not going anywhere. I'm going to actually be more fun than I was before because, right?
Tell them just... If you wouldn't mind, because I think it's such a lovely story, and then we'll jump into the conversation. But so the surgery was literally like 3 days before Christmas. So she did unfortunately have to spend Christmas up at UCSF, and also she was only allowed 2 visitors a day, and they had to be the same visitors. So Tony, Poppy, was there every day, and then my brother and sister and I would alternate days that were sort of our turn. So we got to spend some part of the time with her. But tell them what you made a solid decision to do once you got home with your Christmas.
Oh, my Christmas tree is still up. I still haven't taken it down, and I'm not going to take it down. First of all, Christmas trees are beautiful. I don't know a single person that Christmas doesn't make happy. So I'm having Christmas forever.
I love that.
Right?
I love that. I love that. Okay, so let's get started, shall we? But before we get started, tell us a little bit about you and why you chose lung cancer as an area of focus.
Like Christmas tree.
Well, thanks, Danielle. First, I want to remark how the last time I was here, I looked out and saw so many familiar faces, and now I look out and I feel like I'm really here with family again. And there's this feeling of being all together in the same room. It feels like a reunion, and I just want to celebrate that moment. It's not the same having 25 boxes on Zoom, right?
Yeah.
So
Right.
thank you for being here. So many patients, advocates, supporters, everybody who shares this common bond that we can talk about tonight, but also really don't have to talk about to really understand how we're all connected to each other. Exactly. So, it's really deep, and it's the feeling I get when I go to lung cancer meetings too, and go and socialize with other medical oncologists and surgeons and radiation oncologists. Like, we just get it. We get how tough this is and how important it is to keep making a difference and moving forward. So thank you all for your support.
Hey, sweetest. I know, right?
So about me, I often start off, even with my patients, by saying I was born at Stanford. So it's probably inevitable that I was going to come back. When I ran into a labor and delivery nurse from the 1970s when I was born, I said, where was labor and delivery back then? Because Stanford was a little tiny hospital with a shopping center really far away, right? Now it's a giant campus. And, they said, where those escalators are on the second floor, right across from that? Like, surgical pathology? I was born in Surg Path, I guess. So, why did I become a lung cancer doctor? I guess I was just, drawn back to the pathology of it and, trying to make things better. Yeah. But I also, I had the privilege of being in Northern California and going to Southern California for my undergraduate training in molecular biology, doing an MD PhD out in Chicago, wonderful city to live in, going out to Boston and spending time with the Harvard system and just finding great mentors, and between the mentorship, the people who want to make a difference in lung cancer, the patients who are dedicated, and, things are really tough for a lot of our patients. I said, and right there, I was at the cusp of EGFR resistance and the discovery of ALK. I was in the middle of all of that, where, this drug called PF00234-966, was working on this 19-year-old with ALK positive lung cancer in a phase 1 clinical trial. I'm like, this is amazing. Yeah. So I said, I want to work in this field and be around these people and help and make a difference. So, I've been at Stanford for a dozen years or so. The last 3 years was a blur, but it's great to be back here with family.
Yeah.
Thank you, Joel. And I agree that the last 3 years has felt like a blur. When people say, well, I'll talk about doing something, they're like, well, how long ago was that? It's like literally I've lost those 3 years when I talk about... Yeah, right? It's just weird. It's very strange. But again, we're so grateful for you being here. Thank you so much. And like I said, before we jump into the next wave, which I know Dr. Neal is very excited to talk about, I want to talk about sort of where we've been, where we are, and where we're going. And I know that early in the days, like 10, 15 years ago, or however long it's been that we've been doing this meeting now, we talked about how for decade after decade after decade, I think it was probably a half a century, the needle didn't really move much for lung cancer patients. It was the same old, sort of same old. So starting with sort of chemo radiation combination, then we really moved into this, into this targeted therapy space. So can you talk a little bit about where we were? Like I said, chemo radiation, targeted therapies, IO, and then we're going to jump right into some more specifics.
Yeah, I mean, I jumped into the middle of the exciting times, the beginning of the exciting times in lung cancer. Couldn't have anticipated, despite doing some research in immunology, that, we'd have the major breakthroughs that we did in immunotherapy. But in the, early days of lung cancer, stage 4 lung cancer, it was a decision between bad chemotherapy that caused a lot of side effects and choosing just to get supportive care. And there really was a decision of saying, let's just focus on quality of life alone. A lot of the early clinical trials in lung cancer, including the first trial in erlotinib, the EGFR drug, was unselected patients and compared to placebo, which now we run clinical trials and we'd never dream of running a placebo-controlled clinical trial where the alternative was really just supportive care. Best supportive care, we call it, instead of placebo. We'll do placebo, but it's like, something plus placebo versus something plus something new, right? There's always something in there. But, a lot of those best supportive care clinical trials, we found that there were certain subgroups of patients that were doing exceptionally well. Yeah, like the 19-year-old with ALK-positive lung cancer, or some of the early patients with EGFR mutant lung cancer, where they went on these clinical trials of unselected groups and second-line therapy, and suddenly the tumor melted away, and nobody had ever seen anything like that before on a clinical trial with chemotherapy.
Right.
Yeah, it's pretty crazy when you think about how differently people respond to different therapies, right? No two lung cancers are alike, effectively, right? And that's basically what precision medicine is. So when we say precision medicine, what do we mean? For those, and I know, again, there's a lot of veterans in this room who understand that terminology, but for those who might be new to the game or coming back and watching this post live, what does that mean?
Yeah, it's it's in a way it's like AI, right? You can just kind of throw it out there and it sounds cool. Personalized therapy, precision medicine. We, as physicians, we always want to personalize our therapy. There's algorithms out there, and we can figure out, follow A to B to C. But once we meet a patient, figure out what's really important to them, we're instantly personalizing out of all of those myriad options, like, what's the right path forward? And, I like to think about things like, what is the best possible case from today forward? Not focus on the past and what happened. That's for other people to worry about. But, like, let's take today, whatever today is, and let's say, like, what's the most realistic, best possible case, and how can we do that? Like, there's always a million things that can go badly. We all worry about those things. But what's that best possible case, and how can we see that playing out? And I think precision medicine, when we think about it, is saying, what can we understand about the people, and what can we understand about the cancer, and how can we put those two things together to make the best therapy with the fewest side effects, that makes the most sense?
So from a diagnostic standpoint, assuming I'm a person who's sort of been going through this process, something's been found, and now I've had my scans, and maybe I've had a biopsy, and it's found to be non-small cell adeno. What absolutely needs to happen next for that patient?
And just to back up, non-small cell adeno, right?
Yep.
So,
We're gonna get
lots
into
of kinds of lung
couple.
cancer,
Yeah.
right?
Yeah.
And I usually start off, there's a lot of kinds of lung cancer. Small cell lung cancer is a very unique subtype. It's less than 10% now. 90% is non-small cell. It's a funny name, right? It's not the small cell. That's like, but we're stuck with the name. Within that non-small cell, there's adenocarcinoma that's glandular-like. There's squamous cell cancer that's skin-like. There's neuroendocrine large cell. There's kind of not otherwise specified. But within that non-small cell lung cancer, there's a lot of different subtypes. And that's just what the pathologist sees. That's what they could see 100 years ago under the microscope. But now with DNA technology, we know that the genetics of the cancer are different than the person that the cancer came from. So when we think about where did cancer come from, lung cancer came from a cell in the lungs that was normal and then got mutations and then started to grow. And all those normal programs that say, don't grow, don't do that, don't divide, got overridden. And so a series of genetic mutations have caused it to grow, form a tumor, or even spread around the body. And understanding those mutations can tell us a lot more about the cancer than just what it looks like under the microscope.
And I think this is such an important part of the conversation. I think the WHO should get tested, and I think there's still some discrepancy there. I mean, we definitely know the non-small cell adenocarcinoma patients should be tested. Sometimes the squamous cell patients, right? Like, how is that determined?
I think we're getting to the point where genetic sequencing of the tumor to figure out how it's different, how it's abnormal, what's making it tick, what's making it grow, is getting to be more standard across all solid tumors. And, I think non-small cell adeno, certainly we'd all say somebody who hasn't smoked, who has adenocarcinoma, is high likelihood of finding a mutation that we can target with a pill therapy. That's true. But we're starting to understand that there's other mutations that can help us decide, are there treatments that'll work a little better? Are there treatments that won't work as well in other kinds of cancers too? So increasingly, Danielle, I'm sequencing most of these tumors, and I think we're reaching that point where next generation sequencing, next generation DNA sequencing is unbelievable, right? So
we don't have anything to lose by sequencing everyone.
When we started in this, when we started with EGFR mutations, there was debate about whether EGFR mutations sensitized to drugs like erlotinib, there was debate, or was it just something else that was sensitizing? Was it EGFR amplification or something else? So, sequencing EGFR was a couple of $1,000s and could be done in a few weeks. Now we can sequence hundreds of genes across full exons for a couple of $1,000s in a couple of weeks. So, and we can do tissue directly, which is the most sensitive. You're saying what color are the needles within the pile of needles?
Yeah.
Or we can do liquid biopsy, which is kind of what color needles can we find within the haystack, right? But both of those technologies have gotten so much better in understanding these genetic mutations inside the cancer that I think more information is better in general.
Yeah, so I do want to jump in really quick to the difference between a tissue and a liquid biopsy. But before that, I want to jump back for just a second. And this is a question that we get a lot that, quite frankly, I don't know how to answer. So when we're deciding who receives the biomarker testing, you mentioned erlotinib earlier, which for those of you in the room who have been on it, and I know many of you have, we're talking about Tarceva, right? And most of you have progressed to Tagrisso and, whatever since then. But when that first happened, we were primarily testing never smoking Asian women, right? That's what it looked like. And so when I say who should we be testing, I'm kind of how do we get to that point where we've gotten to, even in the EGFR sort of mind space, where it's no longer just never smoking Asian women, right? How do we get to that place where we're looking at other forms of non-small? We talked about squamous, or even small cell. Is there anything kind of coming down the pike that we should be looking at or thinking about as it relates outside of adenocarcinoma?
Yeah, I think the core DNA sequencing, DNA testing, looking for those important genes that make cancer cells grow, and the other half of it is these genes also make cancer cells not die. There's two programs of there's the program of grow abnormally, and there's the program of suppress the death pathways that are normally controlling all of this. Understanding that whole gene profile and understanding how many mutations there are in a cancer can really help us personalize therapy. So for all the targeted therapies that we have, we have 10 targeted therapy, 10 targets and multiple targeted therapies. We have immunotherapy, understanding the prediction. But I think for stage 4 non-small cell lung cancer today, I would advocate for sequencing the tumors and understanding. And there's not a small number of patients that are never smokers with squamous or other that have targetable mutations that might not have been found otherwise had we not looked at them.
Yeah.
And that one patient is very important.
If we miss, one of the core fundamentals is I believe positive results, right? We believe all the labs, and a positive result is believable, but a negative result just reduces our probability that there's some result there to find. So, an alternative explanation, so there's drivers. We think about these genes that cause the grow signal. We call all those drivers. There's not usually two of those at the same time. So if we find one driver, we say we can stop.
Stop looking.
But if we don't find anything that looks like a driver, then maybe more testing is indicated until we find one.
Yeah, and I think that's important to when we kind of in a minute. Well, I guess we could talk about it now. When we talk about the comprehensive biomarker testing, so you mentioned that there are 10 targets with FDA-approved therapies, right, that we know about right now. But there are also potentially things in clinical trials, and I think this is where it's relevant when we're thinking even outside of non-small cell adenocarcinoma.
So when I think about the fundamentals of cell biology, a tumor is a cell, and that cell comes from people, but it's different. It's got a lot of genetic changes. So, one time a patient of mine said, I said something about your tumor, blah blah blah. It's like, that's not my tumor. That's that tumor over there, right? That's different.
Right,
That's the tumor, and it's true. Like, it is genetically very different than the person that it came from. That's what allowed it to exist in the first place. Right. So when we think about that tumor and the biology, the fundamental change is the DNA, we think, and there's some changes around the DNA that we're starting to understand but are complex to figure out. Chromatin state, what pieces of DNA are open and expressed and what pieces of DNA are silenced, like really complicated stuff. Like, it's not just about opening the Encyclopedia Britannica and figuring out what the information is. It's like certain sections are taped off and the pages are glued shut, you can't read this page. It's really hard to open this page. That's how the DNA works in the cell. But then that DNA creates RNA, which we can also test in tumors now. And, that RNA leads straight to proteins. So the RNA pieces are easier to find. Huge genes that come together, like huge rearrangements, like ROS or RET or ALK, are easier to find by RNA testing because it's two very different genes and you can't sequence the whole thing. And then there's proteins too. So, ultimately it's the proteins that are causing all of the effects of these gene changes. It's on the protein level. So it's the protein EGFR, not the gene EGFR, that's causing cancer division or ALK or all the rest of them. And then there's other proteins that are on the outside of the cell that we're starting to look at and saying, some tumors have these proteins and we can make antibodies and we can start to target these antibodies on the outside that are not fundamental to the biology of the tumor. They're not making the tumor grow, but they just happen to be there and a convenient target to use.
So by sheer fact that they're there makes them a target.
If it's different than self, it's a good target for anti-cancer therapy, right?
Interesting. So now you guys know kind of when we started this by saying that no one single cancer is the same, right? And why it's so important that this type of testing be done, but not only that it be done, but that it be sort of analyzed and then your treatment plan be put out by somebody who can easily understand it. So let's go to biopsies. You mentioned tissue and liquid, and I think this is an important area because liquid is sort of newer to the game, and I think there's some confusion and quite often discrepancies on how and when it's being used. So in your opinion, let's talk about the two. Do you do both at the same time? Do you do one over the other?
Yeah, so a newly diagnosed patient with non-small cell lung cancer, more likely adeno. Like most of the lung cancers that we see in the United States and especially in the Bay Area tend to be adenocarcinomas, probably due to the relative low levels of smoking around here. Mm-hmm. So they're just kind of randomly occurring cancers, truly randomly occurring. Can blame air pollution or whatever else we want to say, radon or cosmic rays from outer space. One time I said cosmic rays from other galaxies and a patient's like, cosmic rays don't move between galaxies. So I have to watch out for the analogies that I use, right? Okay, all right. I'm going to remove cosmic rays from the explanation. So yeah, whatever caused it, we have to say how do we figure out what those genetic changes are? And there's a lot of anxiety with that diagnosis of there's a mass, maybe there's metastases. How do we figure this out? So liquid biopsies, blood, looking for abnormal pieces of DNA, because remember, these DNA changes are not self. There's no EGFR mutations, with rare exceptions, kind of in people without cancer. So if you find an EGFR mutation, even if it's 1 out of 10,000 EGFR sequences, it's unusual. Right. So, that's how the liquid biopsy works, is by determining, in general, this shouldn't be there. But not all tumors are releasing DNA. For them to release DNA into the blood, they have to be dying. And I like to think about cancer sort of in that, growth signals and death signals. I like to think about them as sort of like a slight balance toward growth over dying. Like, tumors are not healthy. Like, I want to think of them as very sick objects, that we can change that balance very slightly. So when they're slightly growing, they're also dying a lot. Like, a lot of the tumor cells are dying. So we know cells can grow every day or two, but lung cancers grow over periods of months, not days or weeks. So that death leads to DNA coming out, and that DNA we can find in the blood. So liquid biopsies are easy. You can do it from a normal lab. It takes about a week for results. But if it's negative, it's not necessarily definitive. If you sequence the haystack for needles and don't find a red needle, that doesn't necessarily mean you found all the needles, right? Or maybe the needle wasn't even in there from the tumor.
So just to kind of recap for those that are watching, so liquid biopsies as they stand today are a very great and amazing tool. And they came on fast and furious, right? Which is fantastic for those whose tumors are literally shedding into their bloodstream. But just because you don't see it there, it does not mean it's not there. So then that's where tissue is still sort of the gold standard.
Right. So, and to do a liquid biopsy, they're not diagnostic for a type of cancer. Just because there's a mass, usually we want to know that it's cancer before we do a liquid biopsy and say, what kind of lung cancer is it? Once we have the tumor, if we have enough tumor, then we can do rapid tests or kind of DNA sequencing within a few weeks to be able to say exactly what kind of lung cancer that is. So the gold standard, if there is tissue, is the tissue testing, DNA. Even RNA that I alluded to, which is a little more sensitive for some of these really rare rearrangements. But the liquid biopsy can be fast and convenient. So many of my colleagues say these are complementary, and it's all about timing, right? When was the CT done? Where was the biopsy done? When does somebody see a medical provider that orders these tests to make sure they're done? And there is a lot of variability, even in Northern California and around the United States and around the world, in terms of what testing is done and what the sequence is. Because, this path from first evidence of lung cancer to having all the information for treatment is different for each person.
And that's where patients need to become knowledgeable so they can do the asking of their doctor and what have you, to say, hey, do you ever give a patient Tagrisso? And they might be asking you that, but they don't know anything about it. But educated patients do so much better.
Yeah, and I do want to focus sort of at the end of this conversation on some challenges and opportunities there, because I think you are 100% right. And there aren't just challenges around educated patients, but also educated healthcare providers, right?
Absolutely.
And so I do want to talk about that. So biopsies, liquid tissue at diagnosis, and then what? What about when a patient progresses?
Well, it depends. You're right. It depends on what the initial situation was, and all of the therapies that they've received up until that time. And I do want to pause. I want this to be interactive, so anybody can raise their hand and ask questions. That's why we're all here, is because and maybe everybody's just used to clicking that Zoom button with the hand that comes up here, so you can just go like this, you know.
Evie, do you have a question for real? Will you grab a mic?
Oh, right, okay.
So we're here together to chat, but we can keep moving too.
Evie's going to ask.
Yeah.
So when the patient is told you're going to have biomarker testing or genetic or molecular, are they all used synonymously, all those words? It's the same thing?
I think those are fair to use. I also usually just say we need more testing to decide what the best treatment is for you first.
Okay. Can the patient assume, well, you shouldn't assume anything, that's why you need to be educated, that whatever panel is run to see if there's a mutation, that it's comprehensive? I mean, will they only test for what they have a targeted medicine for? Or how many things are tested for? Is it like just the 10 mutations, or is it 100, or what?
Yes and yes and yes. Like
Okay.
there is all of this variability, right?
Yeah.
And each path to diagnosis is different. Each healthcare system is different. Each healthcare provider within each healthcare system is slightly different. The guidelines in general encourage testing for the actionable biomarkers. So we're talking about, EGFR2 versions, ALK that we've talked about, ROS1 that we've talked about, RET that we've talked about, HER2, BRAF, NTRK, KRAS versions, and a couple more that are written on our paper.
Mm-hmm.
Yeah, MET exon 14, and one more maybe rearrangement. But it's these are the ones that we have FDA-approved pill therapies. One of the things that concerns us in the academic realm, sometimes patients will be newly diagnosed. It's non-small cell lung cancer, adeno. PD-L1 is high, and PD-L1 is a protein. It's one of these proteins on the outside of the cell. It is not a DNA thing. It is not testable by NGS. It's a protein on the outside. It comes and goes. I've used the analogy, it's kind of like a suntan, like it's sort of a reaction to what's going on from the immune system. And it can be variable more on the outside of the tumor, less on the inside of the tumor. But it's a surrogate for a shield from the immune system. So tumors that are trying to protect themselves and defend themselves from the immune system tend to have high PD-L1. So a high PD-L1 tumor, non-small cell adenocarcinoma, you get both of those results within a day, and you're like, okay, let's just start treatment. But the molecular is important to have first before treatment, and that's a hard 2 to 3 weeks to wait for those molecular test results and to say, let's hold off on immune therapy, which immune therapy is great for many, many, many patients, and bad for a lot of these targeted biomarkers. Like the targeted therapies are much better.
Right, right.
So the path to biomarker testing is still a little bit uncertain. We're moving toward a new staging classification, so the 9th staging classification in lung cancer. Yeah, I started with the 6th staging, so I feel like I have some seniority now, right?
Yeah.
But the 9th staging will include the molecular testing, but it really hasn't been included, so it hasn't been looked at in terms of what are the prognostic factors around that. And we keep finding biomarkers, so the needle kees moving. Right?
Exactly.
Thank you. And I know that if you're in certain areas, it's going to be much more difficult. If you're in the hinterlands, to it be a given that you will be tested. Is that the case still?
I think it's system and provider dependent, and we do want to empower our patients out there, and anybody who is watching this video even later who happens to be newly diagnosed, say, like, what is the molecular status of this tumor? And that's not a simple question to answer, even if I have a report that's 30 pages long in front of me.
Right.
It's usually not as simple as it's EGFR on the top line, right? It's a lot of stuff and it's a lot of thinking.
And I think it's a challenge. So you're absolutely right, Evie. In a lot of, like, we talk to folks all around the country, right? Not everybody has access to the Joel Neals of the world. They just don't. And there are a lot of people being seen in rural community centers where these docs are, and you guys have heard have been here, have heard me say this before. These docs have to see whatever walks through the door, whether it be a solid tumor or a blood cancer. And they have to know everything there is to know about every 100-ish, give or take, of those cancers. That's not even fair, right? So how do we make it easier for them? And I think one piece, and I don't even think it's a small piece, but I think one piece of this puzzle is by patients being their own advocates, caregivers for those patients being their own advocates, family and friends of those patients being their own advocates, and finding trusted, allowing themselves access to trusted information, be it from be it from Stanford's website and the many others out there that are giving you what's happening right now information. Because I've said it before, and I hope to God, I keep saying it, that if you think you knew what was going on last month in lung cancer, it's probably changed today, right? And so it's happening so fast and so furious, and it's so incredibly important.
What do you do when a patient comes to you that's already seen a physician out where they're from in Wyoming or wherever, and that fellow knows nothing about the markers or anything else? He's still working on the chemo, right? What do you do with that patient that's probably not going to come back to you more than once because they don't live in Wyoming, they live, out here, or what that is.
Yeah.
But too often, patients don't get the right information.
I think to take one step back, Bonnie. I think I'm privileged. We're all privileged who are in this room. That anybody who came to me from Wyoming to Stanford probably had a base of knowledge, to be able to do that, right? So it's hard to know what's going on with the people that I don't see. Right. The people that I do see usually have some base molecular testing, but it's up to us to decide whether we believe that.
Right.
If there's a KRAS mutation and the patient says, could there be EGFR2? I say, very, very, very unlikely. We don't have to do more testing. But if the testing hasn't been done, or it just seems like it doesn't make sense, the clinical picture doesn't make sense, then we'll do more testing. And a liquid biopsy, if they're there, is convenient. Getting their tissue and doing sequencing either at our institution or with a myriad of companies that are out there to do next-gen sequencing. I said myriad. I didn't mean them as a company.
Yeah.
But
No,
it's fine to do that. I used that twice. But there's many diagnostic
That's okay. They're on TV
provide,
watching. It's fine.
very, very high quality, tumor tissue testing and liquid biopsy testing. And they're very accessible. So I think it's, do we believe the testing that's been done is more the question, rather than seeing patients that really haven't had any testing, because the guidelines are pretty clear. The pathologists understand it. The medical oncologists understand it. And these things are accessible, at least in the United States, very broadly.
I'll tell you where I was going with that.
Yeah.
Would you ever recommend an entity like ours for that patient in Wyoming to go to look for
Education, information.
Education, where you don't have to do it, because God knows you guys don't have enough time to sit down with the patient and explain all that. I mean, already tonight what you've explained is a lot, right?
Well, we try to have time, for the people that see me, and we do have kind of an online second opinion platform. So I occasionally do kind of second opinions internationally also, and do recommend GoTo as a trusted resource, as well as a number of the molecular targeted groups that have focused in, for those patients who have molecular targets that are already there. There's EGFR resistors and renegades and the exon 20 group and the R positives and the KRAS capers. I thought it was the KRAS.
Cakers.
KRAS.
KRAS
capers.
Yeah.
I have their socks. They're great. So Rick.
So, is this on? Can you hear me?
It's on outside of here.
Okay, so what we're looking for is, I'm hoping there's a way that we can take luck out of the equation. Now, I'm like the luckiest guy on earth because I happen to stumble across the greatest doctor on earth, so I'm very happy with Joel. I know you don't want to hear that, but I'm saying it anyway. I was diagnosed 8.5 years ago, and luckily landed at Stanford. First visit was with Joel, and they did all the testing. He did a FISH test, whatever, found that I was ALK positive. And a lot of people at that time, I think only 30 or 40% of the people actually got tested back then. How do we get the word out there to new patients moving forward to get educated enough to know that they need to ask for the testing to find out if there's something they can do to live longer? Because like I said, I was very fortunate. I was lucky. I didn't meet Joel because I did some research and he's a good doctor, whatever. I stumbled across it strictly through luck. And that should not be part of the equation with lung cancer. And it'd be nice if the education could get out there to new people that you need to search these things out, because if you're not lucky, you're the guys getting the chemo and they don't even know what they're dealing with. So how do we get the world more educated on that? Because I know it's changing every day. It keeps getting better and better and better. But a lot of people miss out, and that's sad.
So I think that's a great question, right? And how do we standardize, and how do we provide the same quality of care across the board? And anybody else is welcome to call me Joel also, if you want, or Dr. Joel, like my father-in-law does when he wants medical favors or wants to show me his kidney stone, right? I think the standardization actually starts with the pathologist, because where does the diagnosis come from? There are companies out there that are trying to diagnose lung cancer just by the blood without a biopsy at all, and do early detection. And I think that's really exciting, but still a little bit futuristic. Right now, our gold standard is a biopsy that says under the microscope, this is lung cancer. And then once the pathologist has that, I've actually worked and written papers with the College of American Pathologists, CAP, and come up with synoptic testing. It basically is like, this is the standard. If you're going to call something lung cancer, you have to do all of these things. And it includes molecular testing. But we still see pathologists, who aren't doing that molecular testing for whatever reason. But it is the pathologist who has the tissue, who can do the reflex, who can start that, which may lead by a few weeks when somebody sees a medical oncologist, right? And so I think we need to start with the pathologist.
We have always said that. Yes. And how do we get a group of pathologists together that's willing to be on those phones when the patient needs them or when the physician needs them?
Well, and I think it's some but not all. And it's similar to, so you mentioned the word reflex, and this reflex testing, right? And the reflex testing has been happening in breast cancer for a long time. Reflex testing for lung cancer might be happening at Stanford and other academic and large community cancer centers around the country and in the world, but not everywhere. And so I think to Joel's point, how do we do a better job of implementing systems? And trust me, I have a whole other living room or two about my thoughts on processes and workflows and implementations that need to go and be, put into place to make this happen. But again, pointing back to you all, the people living with, the people loving the people living with, I think we play a role, and we play a very significant role. And I don't want to any of us to undervalue the role that we play or underestimate what we can get done. You don't need a ton of knowledge. You don't need all the big words. You just need a few, right? And so I think it's incredibly important. And I do want to jump into IO, because then I do want to jump into the actual next wave. But I think it's important also to note, and we had talked about it prior to this meeting, there are, in a lot of instances, more than one right answer for your diagnosis, right? And so I think this can potentially become a challenge, and we talked about this. And so I briefly want you to say, talk from your perspective about how you come to that conclusion, because I think it ties really neatly back in with this precision medicine sort of conversation? How do you choose? And this is we're still on targeted therapies, right? So, or maybe you don't have a target. Like, how are you choosing when you've got maybe a target that's got more than one drug that's been approved for it?
So, just to back up a little step, so I hope that the pathologists, will create what we call, standardized or synoptic reports, right? And that should be a standard for a pathologist reading out lung cancer anywhere in the country. That's one way that we standardize this. And kind of cue the pathologists like lung cancer needs more testing, right?
Yeah.
Of whatever that is at the institution. So then we say, okay, well, now we have the whole picture. So we've moved to beyond, the testing. The testing is done. We look at the molecular testing, whatever the profile is. Hopefully we find a targetable gene, one of the ones that we already mentioned. Mm-hmm. And then in general, but with some exceptions, we'll give targeted therapies first. Why do we give targeted therapies first? There were a series of clinical trials, chemotherapy versus pill therapies. And for the most part, they showed that the pill therapies worked for longer. They tended to have a little bit better penetration to prevent brain metastases or shrink brain metastases that were there in general. But at the same time, chemotherapy works too. So chemotherapy is not a bad first option. Either order is okay. Like we talked about, the biggest problem is missing the target completely and never having access to it. So it's more talking about the sequence when you know about the target than it is talking about, which one comes first. That's more of a nuance. I think we have a question.
Yay.
Oh, we need a mic.
I was one of the people they missed the target. I had an accidental finding, and they did a needle biopsy and couldn't get any tissue couldn't get enough for any tissue to type. Then I did have some more mets within the lung. At what point do I say, we got to do this again? How often should a patient be tested?
So, I think this gets back to the question that I evaded earlier that you were talking about resistance. Yeah, and once we find a target, then we give targeted therapy. If it works really well and then it stops working, that's a great time to biopsy again. After a targeted therapy, after chemotherapy, we don't understand the changes as well. After immunotherapy, we don't understand the changes as well. But I've had a handful of patients that have come to me through other providers that have done very, very, very well on chemotherapy for years. First-line chemotherapy, maintenance chemotherapy for years. And, what I've said is we'll do a biopsy when the tumor grows, but as long as it's under control and things are working, let's continue what we're doing right now. In one of those patients, I actually found an EGFR mutation in another patient who's been around for like almost 20 years now, and kind of labeled as EGFR. I finally did another biopsy when it was growing, and it was ROS1. And I'm like, what? And there was no EGFR. I'm like, I've found ROS1 with EGFR. Usually it's just EGFR. The ROS1's nothing. But, I found a ROS1 in a patient who had very, very slow growing cancer, almost over 2 decades. Yeah. So, there are surprises. And I think getting the tissue and really understanding the tumor, even in the position that I'm in, which is fortunate to have so much access to molecular testing, I've rarely had resistance from insurance companies of doing 2, 3, 4 serial molecular tests, whether they be liquid or tissue testing. And if people, get bills for those, please let people know, let your providers know, don't pay those bills. Yeah. I'm always like, if you get a bill from Stanford that they're like, you have to give a check, or we're going to repo your car, like, let me know, please, right? Don't pay, but don't pay them because they'll never give you a check back, right?
Exactly.
But just don't pay, and we'll figure out how this goes. So, so I think the molecular testing is standardized enough that it should be done. And it's never too late to do more testing, but there is a lot of provider discretion of like, what is the driver, right? Is there a driver? And the fortunate thing about personalized medicine, is every individual, or caregiver or advocate for a given patient doesn't have to worry about everything we're talking about, right? I get to worry about that. I get to go to all the meetings. But then we can dive down into, okay, what's the 1% of the knowledge that you need to know about, and really focus on that.
So you mentioned it's more difficult to look at changes after patients received IO or chemo. What data set would you ideally want to have access to? Would you want to be able to regularly look at the transcriptome? Like, what would you need to be able to be fully informed in that setting?
Yeah, so it's complex. So chemotherapy works on a very fundamental cellular level of preventing cells from dividing. So resistance can happen in a lot of different ways. Immunotherapy, it was an unexpected stroke of luck that immunotherapy worked. For the first time, we've been trying to get immunotherapy to work for 30 years in lung cancer, but it just so happened that tumors put up the shield sometimes, and by breaking down that shield, you can let the immune system get in. So there are a lot of data sets. There are a lot of patients treated with immunotherapy who volunteered for repeat biopsies 2 weeks later. Like, that's a tough sell, right? I'm getting on treatment and I'm getting another biopsy of my tumor. Try and figure out, is it working? Is it not working? What's the resistance? I think ultimately resistance to immune therapy is complex. People have collected resistance, but there's lots and lots of ways that the tumors can put up additional defenses. So what data set do we need? More people participating in clinical trials, a few people hopefully participating in repeat biopsies, which are tough. And unfortunately, liquid biopsies, which are really easy, don't yield the kind of information that we need.
Right.
For finding out this kind of resistance.
I think there's a question from online,
So
and then we'll come here.
please, agree to it if it makes sense for you. But if your provider thinks it's high risk, then they won't recommend it. So.
Yeah.
Yes. So small cell. You kind of asked about this earlier, I think, Danielle. So small cell lung cancer genomically is, in some ways more complex, but in some ways more homogeneous than non-small cell lung cancer. The key driver genes, there's MYC, there's P53, there's RB. But in small cell lung cancer, it seems to be a lot more about these proteins that it's expressing and kind of the state of the DNA, like how closed and open it is and how the chromatin state is. So we're fortunate to, I've gone to a few lectures on small cell lung cancer over the last few months. There's starting to be classifications of small cell lung cancer into a few different groups. One of those types of small cell lung cancer tends to respond well to immune therapy, and the rest don't really. But it's classification by proteins. It's not by DNA. So it's not fixed genetic changes. And what worried me about one of the talks that I heard was, okay, it's great to classify. It's great that this works with immunotherapy. There may be some targeted therapies for the rest, but it's dynamic, and the small cell can change between the different types too. So it's not kind of a hard, fixed, coded base property of the cell. It's a little more dynamic, and I think that might explain why small cell responds, but more transiently to a lot of the therapies that we have. So do I recommend it? I don't generally do it, but sometimes we do. I think we're moving toward all solid tumors being biopsied and tested. Small cell, though, it's harder to test because it's oftentimes very necrotic, dead, and there's not much tissue to test. Yeah.
I think there was, right here in the center.
I had a couple of questions. One was, let's say you find a marker like ALK. How do you decide which medicine to choose? That was the first question. The second question was, one of the things you, of course, worry about are our children. Is there some testing that is being looked at, should be looked at, to see whether you can discover whether they have higher chances for lung cancer before it actually happens?
Yep. So the first question was, like out of the 5 FDA-approved pill therapies for ALK, how do we decide which is the best one? Let's assume we don't have a clinical trial, because we try to open clinical trials that we think are going to be even better therapies, and sometimes they're offered first line. I'll give a very discrete answer to your question. Crizotinib was the first. It was the PF drug with the license plate number I talked about at the beginning. It doesn't get into the brain particularly well. It's not a great ALK inhibitor. Ceritinib was the next one. It causes a lot of GI toxicity. Alectinib came next and had less toxicity overall, got it in the brain pretty well. Data that we saw tends to be a standard of care for most people in the first-line setting. Brigatinib looks equally good, if not better. And then lorlatinib is the newest one, can have more CNS side effects, kind of like even depression and side effects like that. But there are data that say that lorlatinib looks like it works the longest, So I think it's somewhere between alectinib, brigatinib, and lorlatinib. And personalizing, like we talked about, Danielle, is, trying to figure out with a patient, like, what side effects are okay, and, would you rather have a drug that may be slightly more tolerable for a shorter period of time, or a drug that may be less tolerable for a longer period of time? And that's not an easy decision for patient or provider.
Right. Right.
I hope that answers your question. With the second question.
Yeah, I forgot it too.
What was the second question?
The second question was, of course, we worry about whether children have at higher risk. Is there anything we can do to feel?
Of course,
better?
Yeah. So that's actually a really good question, and one that I try in a new patient appointment to kind of mention. These tumors are different from the patient. They're different. They're genetically different. They arose, and the genetic mutations that are in the tumor are not expected to be heritable genetic mutations. Now, there are some exceptions to that. I know that GoTo has funded T790M germline research.
Right.
And, but that's pretty unusual. Like only a few families out there. If we find a resistance EGFR T790M mutation before somebody's ever had a targeted therapy, then we say germline testing is a good idea.
Right.
There's some other, most of these genes that we find in cancers are also ones that can be kind of mutated in the germline and give rise to cancers in a general way.
Right.
But more like, BRCA, usually not P53, even though it's mutated in almost all cancers. It's pretty obvious if there's a P53 alteration in a family. So one of the clues on this next generation sequencing testing when we test the tissue is, most of the time patients are like, hey, why is it only 5 or 10% EGFR? It should be like 100%. There's 2 genes, first of all, in any tumor, and only one has the mutation, so 50% is kind of the limit. And then all tumors are not pure in terms of tumors. They have a lot of normal cells and stroma, like stuff around them. So, 10% EGFR is an EGFR mutation. When I see something that's like 10% EGFR and 50% something else, then I worry like maybe this is something that's actually inherited, right? Because it's in every single cell, the tumor ones and the normal ones. So I do sometimes refer people to genetic counseling.
Yeah.
I don't do the testing myself because there's a lot of implications for families around them.
Yeah. We did that study. In fact, Tony's over there. He's in charge of alchemy.
The Inherit study.
The Inherit study that we did with Posse.
Yeah.
And we're still doing it.
Yeah.
And we had David Carbone called one day and he said, Bonnie, I've got a lady here who has a daughter in California and Carbone's in Tennessee. And he said, could you talk to them and see if they would be interested in getting tested for
T790M.
Yep.
Yeah, T790M. So we did. We tested her, the daughter. Sure enough, she qualifies for a CT scan. She had 2 tumors. She had lung cancer. We would have never found it ever, ever. So, I mean, to me, and this goes back to what, I asked you a while back, I think we have to get as much information as possible. And I think we should always ask patients in clinic, anybody in your family have this? Do your kids have? Because it turned out her brother had it too.
I think this is such an interesting topic, sort of this origins of lung cancer and, sort of its causation and what that looks like. I very recently talked to a patient similar. She's very young. She's from Louisiana. She was diagnosed, zero risk factors that she knows of. She had a strong family line of it, and she made a very controversial and hard decision to have her children genetically tested for T790M, and now she's got a toddler with one. Then you're like, well, now what? Right? Now, what do you do with that information? And I think that's the tricky thing. And I think that's sort of a next wave of sort of discovery from this origins sort of space that absolutely fascinates me.
Yeah.
And maybe it's not just T790. You mentioned P53, and there's other, things that could be contributing factors, but
Well, there could have been something else going on there, too.
So important for people.
Yeah, I think, but in general, in the lung cancer field, we're fortunate that the vast majority of these tumors, are not inheritable.
Yes.
Right.
That
Right.
a patient who's newly diagnosed with lung cancer doesn't need to worry about how does this affect my children besides their own personal care, right?
Yeah.
So in general, these are rare exceptions. But as you talked about, I think the genetic counselors can be a great resource.
And we sent her there before we carried on and did the CT and stuff.
Yeah, because when you do this testing and confirm it, even though the tumor testing can hint to germline things, when you actually know about the germline and start testing family members, then there's a lot of implications for how do people live their lives, right? So that's why they're genetic counselors, not genetic testers.
Yeah,
right.
I could write for the test. That's easy. It's like, what are the implications? So great questions. Thank you.
Yeah, you're welcome.
So obviously, we're going over time, which is fine. And I've already talked to Joel about it, and he's prior to coming here, and he's fine with it too. And we may have to think about expanding this to a longer conversation, even without the around the room. And I know we didn't get to talk specifically about immunotherapy and or combination therapies, but I really do want to jump, or in how everything is truly personalized, because why can one person diagnosed be on a targeted therapy for 10 years, to your point, versus another one maybe progressing in a shorter amount of time? It is so very personal to the individual, and I would love for Dr. Neal to come back and finish that conversation for us. But I do want to jump into this sort of next wave space and some of the things that you're really excited about that are kind of coming down the pipe.
Yeah, no, I think we've talked for many years about all these targets, and we have many more, even 3 years into COVID, than we did before. So there's been research and developments going on. But some of the new and exciting things, so I think one example of a new exciting thing that we didn't really expect or see coming was the HER2 or ERB2 targeted therapy. Trastuzumab deruxtecan, or since we can use trade names, in HER2 is easier to say. And this is now an FDA-approved therapy in lung cancer, worked in breast cancer, high response rates in lung cancer. And it's a fundamentally different nature than any of the targeted therapies that we talked about, because it's an antibody to this protein on the outside of the cell, the HER2, an old antibody, one that was originally in I think 98 or something like that, trastuzumab, but they bound it to a chemotherapy, so a chemotherapy target, a chemotherapy that's so toxic that we don't give it to people. But when you bring it to the cell, it goes into the cell, it kills the cell. And then what's neat about these antibody drug conjugates is some of these chemotherapies stick around after the cell dies and will go into the neighboring cells. So, even though there's one cell with the target that it bound to, it'll start killing, and we call this bystander killing, and it'll kind of kill around that area. So this is the first of an antibody drug conjugate, and it worked much better than pill therapies did. We tried a lot of pill therapies in HER2, but this one works a lot better in this form of lung cancer. There's a whole host of other antibody drug conjugates now, and we're calling these chemo 2.0, right? Bringing the chemotherapy nobody wants chemotherapy. You know, when I talk about chemotherapy with patients, I'm like, nobody ever came into my office and said, I always wanted chemotherapy, right? Nobody ever said that.
I can't wait to try it.
Right?
Yeah.
But when you say, well, it's a more targeted chemotherapy, so it should get more to the tumor and hopefully have fewer side effects for you, or maybe we just can give it an effective higher dose because, you know, we're giving a lot more to the tumor, but it's the same side effects for you as regular old chemo. You know, that's could be better. So there's TROP2 is a new exciting target and doesn't seem to need testing on the outside of the cell. A lot of lung cancers have this. And there's many other antibody drug conjugates too.
So what do you prescribe for a patient who's had all the testing, tested for all of the markers, tested for everything, nothing?
Chemo plus immunotherapy, usually. You know, and many different recipes and combinations of that. And hope that it works, right?
Yeah.
And sometimes, you know, there is immunotherapy for people, you know, high PD-L1 tumors and smoking history. Immunotherapy may have a 40-50% chance of response, and you know, and sometimes when we stop it, still no tumor comes back. Like we're seeing these long-term responses from immunotherapy.
Yeah.
So immunotherapy is sort of the default apart from these targeted therapies. The other thing, Danielle, that we're excited about is kind of cell therapy. So in the same genre, taking the immune cells out of the body, you know, which sometimes don't want to fight the tumor, right? And the tumor put up a shield, but they don't care about the tumor, or the tumor didn't even have a shield. So we're now doing genetic engineering technology where we can basically insert genes into the T cells, into the immune cells, teach them to fight the cancer and target a certain protein and then go and do that. So we're doing that now. It works really well in leukemias and lymphomas. CAR T cells is what they call it.
Right.
We have versions of those that we're using in solid tumors. So I think those are two of the really exciting things. Starting to use these proteins on the outside of the cell as the handles for killing instead of just relying on these, you know, DNA and proteins on the inside in pills. So I think they're complementary approaches.
Well, I think it's fascinating when you refer to it as like chemo 2.0 and that it's targeted chemotherapy. Because to your point, most people when they hear the word chemotherapy kind of sink into their chairs,
They think
right?
that's it.
And what we always tell people, and I'm sure you and your team do too, is that it's not your grandfather, your great grandfather's chemotherapy. Like chemotherapies have come a long way, but more than that, the supportive therapies to sort of counteract any potential side effect profiles have gotten a lot better too. But when I think about targeted chemotherapy, sorry, that was kind of a long-winded way around what my point I was trying to make is, it's not really a lot different than when I think about how far we've come from a technology standpoint, even in radiation therapy, right? Like the way they are able to pinpoint radiation therapy now is kind of how I think about pinpointing this chemotherapy. Like it feels so incredibly futuristic to me, but I think super exciting. I guess my question around these types of therapies are, when are they used? Like, what role do they play in sort of the life of a lung cancer or somebody diagnosed with lung cancers sort of thing? Does it come first? Does it come in the middle? Does it come?
Well, you know, most things that we try, we first try them after the standards of care in lung cancer and see if they work. So I think, you know, the TROP2 antibody drug conjugates, and there's a couple that are out there that have promising data and response rates that are higher than we expect for just single agent chemotherapies. I expect those to be approved in the next 6 to 12 months.
Yeah.
But then once we find something effective, then we say, how do we move it up? Like, should we move it to the front line? And then, you know, what's the benefit? And then what's the side effect too? Because some of these drugs, they're real chemotherapy and they can cause hair loss and they can cause neuropathy and they can cause those side effects that, you know, we tend to not have in, you know, lung cancer, adenocarcinoma, because we have kinder, gentler chemotherapies. I think a lot of the bad reputation of chemotherapy comes from the movies or people that we knew a long time ago, but also people who know friends. And oftentimes the chemo that you notice is not the first chemo they ever tried, right?
Yeah.
If we do a really good job, nobody in the waiting room can tell that somebody else is on chemotherapy, right? That's the hope, and it's only when we're trying the stuff that's older and not as friendly that people notice.
Yeah.
And that's when you start to tell the story.
You're probably too young to ever have seen beaches. But if you ever do, that is what sells cancer patients on the fact that they're immediately going to die. Right?
I think the bottom line about this conversation, and there's not enough time in an evening for us to really cover everything and all these exciting things that are happening right now. But I think the important sort of take home is very exciting things are happening and are continuing to happen. And I think from my experience talking to patients for the last 15 or 16 years is that they want that plan B. Like, what's my back pocket option for if and when my current option stops working for me? And I think you've discussed tonight a lot of ways that we have kind of come down sort of, the highway, I guess, if you will, of therapies that have become options and only looking at some more really exciting things. And I think the last thing I want to say, and I would love for you to comment on, and people who know me know I tout this all the time, is this sort of clinical trials space. Because just like chemotherapy, clinical trials aren't your grandfather's or your great-grandfather's clinical trials. As Joel said earlier, you're either getting standard of care, and or trial drugs. So I think it's incredibly important, and one of the things I want to do for those in the room and those who are watching is say thank you for those of you who have participated, because I think that's a very big missing piece of the clinical trial process, is actually having these conversations with the people who are participating in them, letting them know what's going on throughout in a very respectful and timely and meaningful way. But more importantly than that, thanking them when they're done, and letting them know what the results were. I mean, I think I hear this all the time. Like, these are still some gaps in this clinical trial space, and the patients, they're participating, they are giving back of their time and their bodies, and they want to know kind of what happened. So thank you from the bottom of my heart, and the docs out there like Dr. Neal for participating in these studies, because it is so incredibly important in order to keep moving this needle forward. So I don't know if you...
And we, and we hope, I think of a clinical trial as like, we have to know what's the standard therapy option that anybody could give you anywhere, hopefully in the U.S. And then, what's an alternative, and what are the pros, what are the cons? Is it in addition to a standard option? Is it before a standard option, kind of pushing the standard option back one notch? But we try to have a variety of trials open. It's gotten harder and harder with so much personalization of lung cancer. 10 years ago, it was like we could have a second-line chemotherapy trial open of a new drug for everybody. And now we have to run like a dozen clinical trials for every target out there. So we do collaborate with UCSF and UC Davis, and I'm in touch with all of the academics there to try and make sure that we're not overlapping and redundant, and we're trying to be complementary in our trials. Because driving for clinical trials is feasible. Flying for clinical trials is really hard and rarely encouraged. But we try to open and have open good options of clinical trials, but we can't have it for every decision point every time. And we also hope that our patients never need our clinical trials, right? We really do, because they're doing well on their current treatment. So
I want to give a shameless plug and a shout out to our science and research team and the Lung Match team in particular for helping those who are looking for clinical trials navigate that process, because we all know, or most of us know, or some of us know, that clinicaltrials.gov is not the easiest website to navigate. And we've got people on staff who will help you through that process. So if you didn't know that Lung Match is there for you should you ever need it. And maybe one of the trials is right down the street at Stanford. So does anybody, before I close out, have any questions? I know we're already about 20 minutes over. Just grab the mic.
On. I think it's on.
It's on. In
They
the,
can hear it.
Neal
They
for
can
it.
hear it
Okay.
online. They just
Awesome.
can't hear it in here.
I just want to say thank you to GoTo for the amazing work you guys do. This is my first in-person presentation. I have a question about recurrence. I'm a caregiver. My father is the patient. He is coming, so we're from Hawaii, and I brought him to the Bay Area shortly after they saw that big thing in the x-ray, which seemed pretty darn scary. So he comes back every so often now to the Bay Area to get scanned. And of course, before the scans, even as a caregiver, I start getting my scan anxiety for my father. And I've been watching too much news. And there's been a lot of talk about AI. The MIT group has recently showcased their Sybil program where they're able to look at high-risk patients that might develop lung cancer down the road. And they look at early CT scans and try and predict where, if they might have a lung cancer nodule or growth somewhere down the line. I'm curious if we are doing something similar for patients who have already been diagnosed with lung cancer, and as we watch them for recurrence, if that sort of technology might be applied in predicting whether or not they might have recurrence down the road.
Yeah, so I think that's a great question, and one thing that I've noticed is a lot of my colleagues, like the senior folk in the lung cancer research community, the longer they work in lung cancer, the more that they move toward early detection. Right? They're like, yeah. And smoking cessation too, which goes without saying around here. But early detection. There's blood-based early detection. There's CT screening. We're doing a study of Asian women never smokers at Stanford to try and understand what is this genetic predisposition to EGFR. So it's called the FAN study, and it's in collaboration with UCSF. And I believe so. Yeah. So we're trying to understand this better. It's very complicated, right? Want to get scans, want to get data, and I think data sharing is one of the biggest barriers. So why does ChatGPT work? Because everything is out there on the internet, right? But not every patient wants to put all of their CT scans out there on the internet, for free and donate their data. There's a lot of problems with that. So I think, we'll keep working and collaborating to try and move toward early detection. And I know that many groups and there's a lot of funding around that too. So hopefully, like we talked about, a young infant with T790M, the last thing we want to do is CT scans of the chest at a young age and cause cancer 40 years later, right? So what's that balance? I don't think we know right now. That's a great. I think we're going to be better at early detection. I think 10 years from now, hopefully we can focus a lot around that and move toward blood tests and some sort of low dose CT or maybe MRIs. Who knows?
Yeah, so, I think, and we've talked about the blood tests, and those are. People are working on them from an early detection standpoint, and I even think from a progression standpoint, or I know that there are some. I mean, there are definitely studies that he could potentially look at getting involved in to see if, in fact, progression could be predicted in the blood or seen in the blood before it's seen on any sort of scan. And I think that's what you're asking, right?
Well, if he's going in anyway to get his regular 6-month CT scan, I'm just wondering if there's a database that can collect that. We all, patients who are diagnosed go in regularly to get their CT scans anyway. Might there be a way to kind of get a mass?
Should they be donating their blood at the same time for purposes of research? Yeah.
Yeah, I think the a major barrier is kind of having the idea, having the concept, having the site, and then having the funding, because all this blood test analysis is super expensive.
Yeah. Fair.
So, comes down to funding.
But I am hopeful about the future of early detection. I think 10 years. 10 years from now, hopefully we'll be having discussions like they do in the breast cancer community of the 1 centimeter versus 2 centimeter lung mass, right? Yeah, that's where we need to be. So, Danielle,
sorry, one more question and then we'll close up.
It's not a question, it's actually a comment.
Oh.
And the comment is, I don't want tonight to end without thanking you, Danielle, who has been the host of this along with Bonnie and now, but has carried this through for 10 years? I've been coming here for 10 years, I think, or maybe more. And so I just want to say thank you so much for the living room, for the programs, for all of the expertise that you bring in, and for making it happen for the literally millions of people who are living with lung cancer. So thank you, Danielle.
Thanks, Debbie.
That's exactly what I was about to say, but you said it so much better. So, and Michelle and Bonnie and everybody else here, thank you.
Yeah, I definitely don't do it by myself, and I learned from the best. So thank you, Evie, for your kind words and for everyone's applause. I really appreciate it. We're not going anywhere. We're going to continue to move forward for you. Those of you here in the room and those of you that came before and those that will come after. I mean, it's such an important, passionate place. And those of you who've known me for 10 years plus know that this all started with my mom in 2003 when she was diagnosed. But it has become so much more than that for me. And I couldn't be more honored to be working in this space and alongside all of you and docs like Dr. Neal here, who are really, really in it for the right reasons, as you can tell. Just by his demeanor, his willingness to come here over and over every time we ask. We could not appreciate it more. So,
but Danielle, they only come for the food, which we have none of tonight.
I almost said a cuss word. That used to be my mom's. So, as I said kind of in the beginning, the next living room I have to look is May 16th. I can never remember what the third Tuesday is right off the top of my head. And we will be doing it here. Dr. Millie Doss, who has been here before, who works closely with Joel at Stanford and also works at the VA in Palo Alto, is going to be coming and primarily speaking around palliative and supportive care and what an important role that type of support is in cancer care sort of across the board. So we hope you all come back and watch that. Gathering Hope is on May 9th. Again, Gathering Hope is an opportunity for peer-to-peer sort of conversations, reflections, shared learning, and the like. And like I said, Michelle and Miranda both moderate. I think they just kind of sit there and make sure you guys are all behaving. But it really is a great conversation. We've got about 187 people registered for it. And I think last week we had about 30 some odd people join. So it's kind of a cool, not kind of, it's never kind of, always, it's always a cool event. So if you haven't participated, please do. I do want to, before I do my thank yous, and I already went through the living room things, I think a lot of you, and this is mostly for those of you in the room, and any of you who may have been on the road, remember Rocky Robinson. So Rocky was our backhand, like the right hand, the front hand, I don't know, the left hand, all the hands of this production coming out of that back room. And we unfortunately and very unexpectedly lost Rocky last month. So I just want to give a shout out, not only to him in remembrance, but to Penn Media and this crew, who's a new crew to us, for coming in today and really pulling it off without having our dear Rocky in the background, and he will be greatly missed. But a huge thank you to all of you for stepping up and pulling this all together. I'm going through all of my stuff. Blah, 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 we're not back live. Look at me. That's it. A big, huge thank you to Dr. Joel Neal. Give him a huge round of applause. Like I said, we hope he will be back soon to come and sort of finish this conversation. I think it was a great conversation. Thank you all for participating. Thank you for being part of this. Again, to Penn Media, Onyx and Ash, all of the go-to staff, Michelle Zay over here, who is literally my right hand in ensuring that this program comes off without a hitch. Could not do it without her. And I would be very remiss if not giving a shout out to our supporters. So Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Eisai Foundation Medicine, Genentech, Janssen Oncology, Merck, Mirati, Novartis, Regeneron, Sanofi, and Takeda. Obviously, that's a very long list of people who believe also in what we are doing and how important it is for all of you. So thank you, thank you. Get some coffee, get some wine, have some cake, and we will see you all next month.
That one cake.
Amy brought it, smartass.
You know what? We still have our holiday card free, so we have this.
So I'll be brave if you're brave. I'll be, but only